Hello, everyone. So it is 2 o'clock and we will begin. I hope everyone can hear me. I know we're getting used to this new platform. So I will begin. My name is Lindsay Bornheimer, and welcome to the Clinical Intervention and Treatment for Suicide Risk concurrent session of the University of Michigan Injury Prevention Center Suicide Prevention Summit. Again, my name is Lindsay Bornheimer. I will be moderating the session, and I'm so glad that everyone is here. As a reminder, this session is being recorded. Only the presenters and the moderator are visible and are allowed to turn on their audio and video. If you have a question for one of our presenters, please ask it by typing it in the question and answer box. That's on the right side of your screen. You can put it in at any time while the presenters are speaking. That is just fine. And be sure to indicate who your question is for by including the presenter's name at the beginning of your question. You'll also notice to the right-hand side of your screen that you can go between the question and answer section for this session and also the question and answer section of the event, the larger event. So make sure that if you're putting in a question for the presenters in this session, that you are using the session tab. Again, you can send your questions throughout the session. I'm going to be reviewing them and we will answer them as time allows. So our presenters will each have 15 minutes to present. There are 2 other concurrent sessions that are happening right now. And as much as we want you to stay the full session and listen to our wonderful presenters, please feel free to jump between sessions. Recordings of all sessions will also be released in the coming weeks. Now, please join me in welcoming our abstract session presenters. I will be introducing everyone at this time. So that there's no interruption in the flow of the presentation. So we will go from each presenter again without that interruption. So please welcome Dr. Jennifer Johnson, who is a CS Mott Endowed Professor of Public Health, Professor of OBGYN, and Professor of Psychiatry and Behavioral Medicine at Michigan State University. And second, we have Dr. Mark Ilgen, who is a research career scientist with the VA for clinical management research here in Ann Arbor, Michigan. And also he's a professor in the Department of Psychiatry at the University of Michigan. And then third, we have Dr. Brian Ahmedani, and this is a senior scientist and director of the Center for Health Policy and Health Services Research at Henry Ford Health System. And lastly, we have Dr. Linda Dimeff, who is the Chief Scientific Officer at the Evidence-Based Practice Institute, also the Institute Director at Portland DBT Institute, and an adjunct clinical faculty member in the Department of Psychology at the University of Washington. So presenters, when it is your turn to present, please turn on your audio and video and then turn them off after you're done. And we will move through the presentations, 15 minutes each, and then we will resume coming back together to talk about some of the questions that our attendees will have. So we are ready to begin, and I will turn it over to our first presenter, Dr. Jennifer Johnson.
Good morning. Thanks so much for having me. I've been looking forward to talking with all of you. If you could go to the next slide. So today I'm going to talk a little bit about the intersection of the justice system as an avenue for suicide prevention. I don't have any conflicts of interest, though I have a large and wonderful team, not the least of which is my partner in all of this, Dr. Lauren Weinstock from Brown University. And next slide. So the US criminal justice system is larger and more complex than I think many people realize who don't work in the system. This is a figure showing it in many of its complexities. It's actually called the sequential intercept model because every one of these boxes is a place where behavioral health services could potentially intervene. This could be mental health services, this could be substance use services, or suicide prevention. And just to give you some sense of the reach of the system in the US, we have 240 million 911 calls per year, 53 million police contacts. Today, I'm going to talk a lot about Intercept 2 here, which is arrest and jail detention. And this is where you go if the police take you, you typically go to arrest and jail detention. You may not even be charged with a crime, but typically you're booked for a few days until you're bailed out, they charge you, they release you, or they figure out what to do with you. That's 11 million people per year. I think of that sort of like the emergency department of the justice system. And then if you are sentenced for a crime, if you're sentenced to something short, you'll probably go to jail, something long, you might go to prison. There are various aspects of community reentry. So again, think of this as a large system with a lot of different nodes where behavioral health services could potentially intervene. Next slide. So again, like I said, there's high reach of the system. About 1 in 34 people is currently justice involved. About maybe on any given year, maybe 20% of people with addiction in the US are justice involved. And actually the 3 largest mental health treatment providers in the US are jails. Next slide. So, like I said, if you think of jail sort of like the emergency department of the justice system, it's a place where you see a lot of people, they're typically in crisis, and you don't have them for very long. So it's a high volume, high crisis kind of place. Mental health disorders are the rule, not the exception. Maybe 66% of people have mental health disorders, 75% have substance use disorders. And like I said, they're often arrested in moments of crisis, typically the incidents leading up to an arrest indicate increasing crisis in someone's life. And, there has been some attention paid to suicide risk, especially in the first 24 hours after arrest in jail. However, there's actually very high suicide risk after release from jail. You think about people return to the community, they have access to firearms, drugs, cars, they may go back into addiction. So that time after release is actually very risky. Next slide. So, and again, if you think about, like I said, the jail, like the emergency department of the justice system, high crisis people in a moment of crisis, every suicide risk factor listed here is elevated among people in the justice system. A serious mental illness, personality disorders, conduct disorder, antisocial personality, substance use, chronic pain, health problems, life stressors, lethal means, stressful life events, just the number of deaths in their networks and crises in their networks is very high, and the exposure to suicide is very high. Next slide. So, and actually, more than a third of suicides by males in the US and about 1/8 of female suicides are experienced by individuals with a history of criminal justice involvement. And if you look at the National Violent Death Registry data, about 9 or 10% of suicides where the context is known, the context includes a recent criminal or legal stressor, which can include arrest. So, we really started to think about this in terms of, I love that slide that Jane Pearson showed about which systems touch people at risk for suicide. And actually, if interventions that work in the emergency department work as well during pretrial jail detention as they do in the emergency department, we can have a big impact on population level suicide risk in the community by intervening in the jail. Next slide, please. So usual care in the jails, I guess I just wanted to give you some sense of this. So most jails are run by counties or municipalities. Occasionally in very small states like Rhode Island, they're run by the state. But again, like I said, it's high volume. So a mid-sized jail might admit 13,000 people per year. That's a little over 50 a day. And again, you think about they're coming in often high or drunk or manic or psychotic or otherwise impaired. You have a couple days to try to triage, assess them, and then they're released. And the release times are often unpredictable. They depend on the courts and not the jail itself. So, you know, they're doing their best they can, trying to keep people alive and occasionally trying to connect them to services, but they don't even typically have the resources to connect them to community services. These are some pictures of standard care for suicidality in pretrial jail detention, which is you go to a special sort of holding cell, they call it solitary. You wear this quilted outfit that people hate so that you cannot hurt yourself with it. You don't have privacy, and in some jails, they don't give you food you can eat with a fork. You have to eat something called patty. So it's really not very pleasant, but like I said, I don't blame the jail because they're doing the best they can with extremely limited resources. Next slide, please. So again, you know, to drive home the point, many systems serving those most at risk are either low resource systems or they aren't treatment systems at all. Next slide, please. So this is the context in which Dr. Weinstein and I are leading and have now completed the SPIRIT trial. This was actually the first randomized trial of any intervention for suicide risk as individuals transitioned back to the community. And I think it might have been the first randomized trial of any suicide risk intervention for people in the jail at all. And again, the idea is to use pretrial jail detention as a marker for temporal risk, for person level risk, intervene, and then use that as a way to reduce suicide levels, especially for hard to reach folks in the community. Next slide, please. So, you know, jail detention is a critical moment to engage and intervene. We enrolled and randomized 800 people in pretrial jail detention in Rhode Island and Michigan who were at risk for suicide at release. And we defined that as either a suicide attempt or a method with intent in the past month. Most of our folks in this sample they never get to Columbia of 5, they don't plan, they have the impulse and they act. We randomized them to Stanley and Brown safety planning intervention plus telephone follow-up. You know, this is this idea of planning ahead for what can you do in potential suicide risk crises. And then the phone follow-up, what we did is we had community mental health clinicians who, you know, worked in community mental health. We hired them as moonlighters on this project. We would go in, assess people during the day in the jail. The clinicians would come in the evening, do a safety plan, and then when the person was released, follow up with the person maybe 4 times or so by phone in the community to problem solve, you know, suicide risk factors, try to connect them to care, update the safety plan, et cetera. It wasn't treatment, right? But it's one of these brief interventions meant to stabilize people and try to connect them to treatment. And a lot of our participants, this is the first time anyone had ever talked to them about suicide. They really are, many of them, people who are out of care. And we followed them for a year after release to the community. Next slide, please. You know, we looked at cost effectiveness, tried to make it real world, because if you don't do real world, I mean, the justice system is very real world. Okay, next slide. So to give you some idea, you know, it wasn't hard for us to find these 800 people at high risk for suicide. And, you know, when we say a suicide attempt in the past 30 days, these were typically suicide attempts in the community because most people had just been arrested a few days before. Our colleagues told us that this was the sickest suicide sample they had ever seen, you know, worse off than ED or veteran samples, though all of them need help. But the risk level was just very acute. Many were psychotic, many had lifetime mania. We were actually had good success following them. Like I said, many said that this was the first time any of them someone had ever asked them about suicide. And we had good, I would say, compliance with the intervention. I don't love that word, but by and large, we got the in-jail sessions unless for some reason the person was released between when we met them during the day and when the counselor came in the evening. And they actually completed an average of about 3.5 of 5 of the planned sessions, again, which is really good because they're often released to homeless situations or other situations. And just to give you some sense of the sample, in a sample of 800, we actually followed, some of them were sentenced to prison, were not followed, so maybe 660 who were released to the community. We had 16 deaths, and that is, they were not primarily by suicide, several were homicides, and some were overdoses and a few were suicides. But this is a 2.5% mortality rate in a sample with an average age of 35. So again, high risk context, and we had more than 1,200 expected adverse events in the study. Lots of hospitalizations, lots of suicide attempts, a lot of things. Next slide, please. So, in the control condition, it's interesting because we powered the study. Our primary outcome was actually suicide events, which included suicide attempts, other behaviors, and suicide-related hospitalizations. But actually, that we could have just done the study. It ended up being powered for suicide attempts. There were that many suicide attempts. So in the control condition, almost 20% of our sample had a suicide attempt within 4 weeks of release from jail, and 41% had at least one attempt by week 52. And it was there was value, I think, even in our enhanced standard care control, which was a resource guide. We were surprised when we asked people at the end of the study how much they just appreciated the research assistant calling to check up on them. That's not ideal care, but it just goes to show that there aren't a lot of resources or attention in this population, and a little can go a long way. Next slide, please. So you'll notice the results aren't on there, right? So we are just unblinded the results within the past few weeks. We're looking to publish them, and so I can't give you the full results, but what I can tell you is that our initial analysis looks really, really promising. We were really very pleased, and I think, there was doubt in some quarters about whether a brief intervention would work in such a severe or a primarily substance using population. And I guess I'll say this, that we're really happy with the outcome, so stay tuned. So I think, the important thing here is that this is feasible, possibly, probably effective, and that this can happen. And we have additional analyses looking at this interplay between substance use and suicidality, because the truth is, if you have drugs with you, they become access to lethal means. We have people who attempt suicide because they're discouraged about their substance use. The substance use can be itself a suicide attempt, or sometimes they use substances to decrease their inhibitions to make a suicide attempt. And we also found that when they overdose intentionally, they don't seek treatment. And if they are unconscious and someone takes them into treatment, into the emergency department, they often don't disclose that the overdose was a suicide attempt unless explicitly asked. So one of the take homes is, if someone overdoses, ask if they did that with any intention to die. Next slide, please. And I think the next slide is my take-home slide. Yeah, so, a lot of people at high risk for suicide are served in these non-treatment systems. Think about the justice system. There is so much that can be done here. We have all of these tools, and this is a system that could use everything that we can do to support them. Their motivation is the problem, capacity is the problem. So please think about the system And I guess I would say, anything you can do for suicide prevention for folks intervening in the system in any place, from police contacts to prison, I think is really valuable. And that's it. Thank you.
Wonderful. Thank you, Dr. Johnson. I will take over here with my presentation on another or a different brief intervention to reduce suicide in a high-risk group. And this is a study focusing on an intervention that we call crisis line facilitation. And we're studying this in veteran patients who are hospitalized for a recent suicidal crisis. And I should note that this is a study that was funded by the VA and conducted in the VA healthcare system. Next slide, please. So for today's talk, I want to provide a little bit of an overview of why we're studying this specific intervention, and combine with the description of the intervention content, and then provide some preliminary or early results from a randomized trial that we conducted of this intervention in the VA. Next slide. So this slide is intended to convey why veterans are a high-risk group when it comes to suicide. And there's actually a lot of information crammed in here, so I'll try and unpack it a bit. The darker two lines are represent veterans, and the lighter blue lines represent the non-veteran population. And what you can see is that veterans overall are at higher risk for suicide. They have a higher suicide rate than the general US population. And some of this difference is due to demographic factors, mainly that veterans are much more likely to be male and men are much more likely to die by suicide. But demographic factors, even when you control for those, don't fully account for these differences. The other trend you might notice there is that the overall rate of suicide is gradually nudged up, at least through 2017, and that veterans are increasing at a greater rate than the general US population in terms of their rates of suicide, and that's even more striking when you account for some of those demographic differences. So as a takeaway, veterans are definitely a high-risk group, and unfortunately it appears as though that may even be more true as we progress over time. Next slide, please. So in response to this, the VA has rolled out a number of initiatives to try and address suicide risk in veterans. And the Veterans Crisis Line is arguably one of the most visible and hopefully one of the most accessible aspects of those suicide prevention efforts. Briefly, the Veterans Crisis Line is an easily accessible resource for veterans and their families. It provides 24/7 services and has been, by most metrics, extremely successful in reaching individuals. This slide's a little old, so we have, there are now over 4 million calls to the crisis line, over 500,000 chats, closing in on 200,000 texts. So the VCL is a resource that's widely accessed and is readily available to potentially high-risk veterans. Next slide, please. The VA has worked hard to publicize the VCL, and if you work in the VA or have even been inside a VA hospital, you likely have encountered some of the marketing materials, including posters. They have ads on Facebook and Twitter. There's a lot of what the VA calls swag, but there's kind of pens and magnets, brochures in most mental health treatment settings affiliated with the VA. And as I mentioned, there's a lot of reason to feel good about the number of people who have accessed this service of the VCL. However, there still remains a chance that the VCL is being underutilized by high-risk veterans, or maybe not utilized at the time where it could have the most impact to reduce suicide. And that was what really motivated this work, to think about what could we do to engage high-risk individuals and encourage them to use the crisis line to help them stay safe during a high-risk period. Next slide, please. So we developed this single session intervention that we call crisis line facilitation. This intervention combines a little bit of motivational interviewing and just background information about the crisis line. And then it also uses behavioral rehearsal. And by this, we mean that the at-risk veteran actually calls the crisis line with a therapist in the room to practice making that that outreach behavior, and then they process it with the therapist afterward to talk about what they got out of the call, what sort of things they learned. And you know, I self-identify as a cognitive behavioral therapist, and I think it's tempting sometimes as a therapist to get it drawn into the cognitive side of CBT, having in-depth discussions about patients' beliefs, their thoughts about the world and why they do what they do. But it's sometimes hard to think about what are the behaviors that could actually help keep someone safe. And that was what we tried to do with this intervention, is put some of the emphasis on that behavioral piece. And you might think, you know, why are you practicing using the telephone? Everyone in this study probably knows how to do that. But the idea is that when individuals are under stress, that they often lose sight of different ways of perceiving the situation, different ways of coping, and they're more likely to make a good choice and a safe choice if they practice that before. And so in the pictures in this slide are, within a military context, all the different ways that the military practices how to cope with high-risk situations. And that can include very complicated scenarios. But if you look at the photo of the kids kneeling on the floor, for those of you outside the Midwest, this is a tornado drill where kids file into the hallway and put their hands on their head and practice what to do if a tornado comes, if there's a tornado warning in the area where their school is located. And this is an example of a very basic set of behaviors you're trying to reinforce. But still, even when people know what to do, practicing those behaviors so that they're prepared when a high-risk situation comes can actually increase the likelihood they'll engage in those behaviors and hopefully be safe. So that was the underlying thinking and why we wanted to practice the use of the VCL. So this is a little more information about the CLF intervention. We published a paper that's in print now in 2021, describing the intervention and kind of the nuts and bolts of what goes into it. Next slide, please. This slide gives just a little bit of information on the proof of concept for this intervention. We looked at measures like comfort calling the VCL, self-efficacy to call the VCL, and examined whether that looks different in individuals who get a practice session in this crisis line facilitation or those in a control condition. And what you see here is that comfort and confidence in using the VCL increased substantially in those people who had the intervention relative to a control condition. So this made us think that maybe there's something positive here, and we wanted to examine it further in a full-scale randomized trial. Next slide, please. So we conducted a study in veterans who were hospitalized for a recent suicidal crisis in an inpatient psychiatric unit in two different health care clinics, one in Ann Arbor, one in Battle Creek, Michigan. And we looked through the health record to identify those who might be eligible, and then ruled out anyone who'd used the Veterans Crisis Line within the past year to get a group that was relatively new to using this services, and in most cases had not used the VCL before. Next slide, please. In this trial, we recruited 307 participants. You can see how the randomization broke down there. And they were then reassessed at 3 months, 6 months, and 12 months. And our follow-up rates were quite good given the severity of the patient population and the complexity of the cases we were working with. Next slide, please. So in looking at how our sample broke down, this is pretty similar to what you would see if you looked at the general census in a VA inpatient psych unit, and it's certainly representative of the geographic region we're in. The participants are on average middle-aged, predominantly male. The vast majority are white, non-Hispanic. And if you look at number of suicide attempts, about a quarter to a third of participants in this study had never attempted, and the remainder had attempted once or more. Next slide, please. So in terms of the study results, and these are preliminary, but I think we're feeling pretty certain that this represents the main findings for the study. There's a lot of information here, so I would just concentrate on the two rows that have the letter A at the start. What we saw for calls to the VCL, there were no differences between conditions, so at least not significant differences between conditions. So those who received the crisis line facilitation intervention were no more likely to call the VCL than those who did not. But when you look at suicide attempts, and this looked at both first and repeated attempts, you see that those who received the crisis line facilitation intervention were much less likely to attempt during the follow-up interval than those who received the control condition. Next slide, please. The next two figures just kind of graphically display those results. Here you'll see the overlap between the two conditions where we don't see a significant difference in reaching out to the VCL, although you can see that it does kind of look like it's moving in the right direction. Those findings are not significant. Next slide, please. And for attempts, here's where you see that the lines separate, and those who received the crisis line facilitation intervention were less likely to make subsequent suicide attempts during the follow-up interval. Okay, next slide, please. So just to sum up, we found that it was feasible to deliver a single session intervention that was focused on encouraging use of crisis lines during an inpatient, to deliver that during the inpatient stay, and that participants were receptive to receiving that information and engaged in those sessions during their stay. We did find that those who received the intervention were less likely to report a suicide attempt during the follow-up interval. However, we didn't see any differences between conditions on use of the veterans crisis line. So this underscores the need to understand the mechanisms of action. We thought the way this intervention would work is through use of the VCL, and so more work is needed to understand why we're seeing the results we're seeing. In terms of limitations, this type of study is difficult in terms of looking at rare events like suicide attempts. I didn't include the results here, but in our sample, even though they're a very high-risk sample, they were less likely to make an attempt than in the study that Dr. Johnson reported. It was around 20% of the sample who made attempts in our sample. It's difficult to follow, assess, and model outcomes that are relatively rare, like suicide, over time. There's one limitation that I think is important to highlight just from a practical standpoint, and that is in a research study, we weren't able to really, I think, maximize the potential impact of the crisis line facilitation intervention in that patients, when they were on units, didn't have access to their own phones. So we weren't able to make the practice experience as realistic as it could have been. if someone could have used their own phone, we could have programmed the number into that phone, et cetera, and made it a better experience. But despite that, we feel that these findings show promise and are excited to think about what are the sorts of behavioral things we could reinforce and practice in treatment to help keep high-risk individuals safe. Thank you.
All right. Thanks, Mark. So I think I'm next, looks like. So it's always a pleasure to present alongside or after Dr. Johnson and Dr. Ilgen, both excellent projects and great researchers in this area. So I want to talk a little bit about our study that's ongoing still, and I'll clarify that a little bit at the end. We can go to the next slide. I'm Brian Ahmedani at Henry Ford Health System, and the current project that we're going to talk about is supported by a cooperative agreement from the National Institute of Mental Health, and it includes 6 different health care systems across the U.S. We can go to the next slide. So, I think all of this has been covered already, but just to set the stage, we've had, obviously rising suicide rates for many, many years over the last couple of decades. Although we did see the first decline record in the last couple of decades in 2019. But nonetheless, we have a pretty substantial problem. And over the last couple of decades, the rising rates of suicide have been increasing more than any of the other top 10 causes of death in the U.S. In fact, it's the only one of the top 10 causes that's been increasing, obviously, aside from COVID now. But what we've obviously been learning over the last couple of years, and really this happened in the last 2 decades, that healthcare systems have to be an important environment to prevent suicide. In fact, if you go back to the first national strategy on suicide prevention in the early 2000s, there was no mention at all of healthcare systems and their contribution or role in suicide prevention. So fast forward 10 years and now 20 years to the next iteration of the national strategy and where we are currently, after having developed dozens of new interventions and strategies, we are in a new place. But nonetheless, compared to most medical areas, we're in our infancy stages. But nonetheless, we have several interventions that are now developed and have started to be implemented in healthcare systems. We can go to the next slide. I always like to set the stage for the impact and importance of healthcare systems by showing this, and it's probably one of the simplest studies that we've ever done, but actually has been pretty important in guiding a lot of the work that we've done across our mental health research network in understanding opportunities for prevention of suicide. What you see here is a chart, organizing and understanding how people interact with the healthcare system in the year before suicide. And we published this, 6 or 7 years ago now. But it includes data from over 10 years of healthcare visits and over 5,000 people who died by suicide. And what we found, is that pretty much everybody, or most people, over 80% of people have some sort of healthcare encounter in the year before they die by suicide, and half of people are making those kinds of visits within a month before their death. Now, previously we always thought, well, this has to be a mental health problem, but we're not really seeing that. In fact, only half of people who die by suicide have a mental health diagnosis. That was pretty consistent with the CDC report that came out a couple years ago, saying the same thing. Only about half of people who die by suicide have a mental health diagnosis, which means, and the other part of the story is that is that people aren't always going to behavioral health. In fact, only about a third of people get to behavioral health before they die by suicide. So that means in order to do strong suicide prevention in healthcare systems, we really need to branch out of behavioral health, where over 70% or about 70% of people have visits in primary care, and almost 70% have visits in medical specialty settings, outpatient medical specialty settings, not part of behavioral health, without a mental health diagnosis. So most of the visits are actually occurring outside of that setting. We can keep going. 20 years ago, actually, it's hard to believe it's been 20 years ago, but 20 years ago, Henry Ford decided to develop a new program called Perfect Depression Care in response to the Crossing the Quality Chasm report from the Institute of Medicine at the time. And that report basically highlighted gaps in fragmented healthcare and how the healthcare system is fragmented. And after launching that program, you know, what we tried to do was say, okay, if we were going to provide a utopian healthcare system for people with depression, what would that look like? How would that be implemented? And so the system implemented this specifically for people with depression, but realized that it was broader than depression. That the data were saying that, you know, pretty much everyone with a mental health condition is at least some sort of increased risk. So we put in a new system of care, including lots of different elements of helping people stay engaged and evidence-based practices and high quality psychotherapy. And we subsequently saw that our suicide rate dropped by almost 75 to 80% and was sustained for well over a decade at that very low rate, including reaching zero suicides in 2009, and actually for 6 straight quarters. All of that stimulated a movement. It stimulated a movement in the national strategy. It stimulated an international movement. And really coupled with that, along with the invention of several new evidence-based practices in suicide prevention, the field continued to evolve. And so we've developed this new model called zero suicide. Recently, a few years ago, NIMH came out with a new funding mechanism to support zero suicide, studies in healthcare systems. And so we launched a new proposal and a new project to investigate the implementation of zero suicide across 6 different learning healthcare systems across the country, which serve now over 10 million patients a year. And so you see all of those systems: Henry Ford in Michigan, Kaiser Permanente in Washington State, Kaiser Permanente in Oregon or in the Northwest, also Kaiser in Southern California, Northern California, and Colorado. So we have 6 different areas of the US with comprehensive data capture. And all of these interventions can be delivered in any health system. But we really need comprehensive data to actually see whether those interventions impact suicide attempt and death rates over time, and a huge sample. So it's important to note, we can keep going, that all of the interventions were actually chosen by the health systems. Zero suicide, as you know, is a large menu of evidence-based interventions organized by categories. So leadership, training, identification of people at risk, engagement of people in care, treatment, evidence-based suicide-specific treatment, and supporting people in transitions, as well as quality improvement, ongoing quality improvement. But each of those areas has several different options. There are multiple screening tools, assessment approaches, evidence-based treatment approaches, brief interventions, engagement models, And so systems actually choose. And what we wanted to do, so we allowed systems to choose what interventions they all implemented locally. And then we came and we worked with them to develop local metrics and then cross-site metrics to measure that implementation. We have been working to measure both what systems wanted to measure, as well as then our main goals are to evaluate the fidelity of what they wanted to do and the outcomes associated with those different approaches to suicide prevention. And really this is to understand, the grant is really to understand, do the pragmatic adaptations of this model that are implemented in healthcare systems lead to changes in suicide outcomes, both attempt and death outcomes. We can keep going. And we're using a interrupted time series approach across all these different systems. So we have all of these systems that are implementing these models. It's important to know that all of the patients have insurance coverage, although it is quite a diverse range, including subsidized programs, Medicare, Medicaid, employer-sponsored, and individual insurance. So it's not just commercial insurance. This is people in a wide range of different insurance categories across our systems. The data that we have at all of these sites include all of the medical and mental health care. We have demographic information, and all of that is housed within a system called the Virtual Data Warehouse, where healthcare, each of the local healthcare systems takes their claims and electronic health record data and puts them in the same data definitions and formats so that we can do these large studies across multiple sites using the data that are already collected for clinical purposes. And that's really important because it allows systems to use these kinds of metrics to do pragmatic evaluation of their local programs. Sometimes they don't have the resources to do research-based measures. And so our approach was to create pragmatic approaches for systems. And we covered all of these different kinds of healthcare settings. We can keep going. So the proposed project really focuses on evaluating the clinical components, although the partnerships we're developing with our health system leaders address the first operational or leadership element of zero suicide, and also the quality improvement element. But the main focus here is to understand how the clinical flow or clinical care pathways work in each system. So we focused on variations of implementation of the identify component, the engage component, the treat component, and the transition component. And all of these data are stored in our local data systems. We've matched all of those data systems to our state and government mortality records to also obtain suicide death information. And now, obviously, we're only about 2/3 of the way through the study, so we don't have the final data yet available. And of course, it was all interrupted last year with COVID. So all of these things had to change. But here are we did a big implementation paper that's under review and hopefully will be accepted soon, fingers crossed. But what we try to do is map out all of the different strategies that each of the systems was implementing across their place. And so here is a map of all the different kinds of elements of treatment, of engagement, of identification, transition, that each of the systems was using at their local places. It's really complex, actually. And so our goal is to evaluate each individual approach within each setting at each system, but then also to compare and contrast those approaches across systems. So it's sort of, as a system implements a process, there are an intervention site, and we measure using interrupted time series their pre and post. So they're both their own control and their own intervention. but then compare that to the other systems that aren't implementing that approach, so that we have within and across system controls for each intervention. And then we are able to bundle all of these interventions together so we can see what the impact might be for bundles of services or pathways of services on outcomes. And we can keep going. So we tried to have, first thing we did was try to make sense of all that, because it's a really complex package of interventions, and it represents probably a microcosm of the various packages of implementation that systems use across the country for zero suicide. So basically, the steps work like this. In a variety of settings, all of our systems use some sort of screening approach. If that screening is positive, then we do some type of assessment. Many of the systems have chosen to do the Columbia. Many of the systems have started with a 9th item of the PHQ-9, spun into the Columbia, and then we do an assessment. Then pretty much everyone gets a safety plan or some version of a safety plan, and then that pathway spins off into the risk level spins off into a desired care pathway that includes some sort of evidence-based treatment or approach, and in various settings. So all of that happens out of out of each of these different settings, and then we also have and need to think about follow-up after care, and then keeping people engaged in the system after they initiate services. So that's kind of how we tried to make it simple, even though all these different approaches were used. So like I said, we don't have final data yet to share, because we still have another couple years or year and a half left in the study. But we have begun to collect quarterly measures of each of the research-defined metrics, or the system-defined metrics, which include suicide attempt rates, suicide death rates, follow-up rates after emergency, inpatient, and other types of visits, screening rates, assessment rates. We're working on developing safety plan, metrics, so that we can understand how each of these processes work, and then bundling them together. We are also working with patient stakeholders to understand their experience, particularly as they receive substance use care, because we noticed as we were doing this that the substance use treatment, use of suicide prevention care in substance use services was very different than the way that it was implemented in behavioral health and other parts of the system. We're also trying to understand a little bit about the quality of the safety plans, and not just whether or not there was one recorded. And so we are trying to do some natural language processing there. And also simultaneously trying to understand whether opioid prescribing guidelines impacted suicide at all during this period, as the periods in which we're evaluating implementation across the last several years and out into the future also overlap with changes in opioid prescribing. So we wondered if that may have impacted suicide at all for that population as sort of a population level means reduction approach. So all of that work is underway. We can go to the next slide. We are in the process of now, we have several papers that are out. So we highlighted several measurement questions in Bobby Joe Yarborough's paper that you see. That one is already published. We have an implementation paper underway. We have also a paper under review now looking at various denominator definitions. What we've found talking with health systems is that all of them have different ways of understanding how to count the population that they're supposed to be tracking for developing local suicide prevention metrics. And so we worked on testing a bunch of different denominator approaches and looking at the difference. And really the truth is that there really isn't much of a difference, but the big message is to stay consistent. And then we also have done a paper on our identify component, starting with screening and then working to assessment, looking at the quarterly implementation of all of those activities. So again, it's none of this is final yet, and we have a little ways to go, but I think this project will yield some important results. And importantly, we will probably also learn how systems adapted these processes during COVID last year, as systems had to make massive shifts in the way they provided care during that phase. So I'll stop there.
Brian, that is so impressive. Hello, everyone. I'm Linda Dimeff. I am the Chief Scientific Officer at Jasper Health. And I just want to say what an honor it is to be not only on this panel, but with all of you. I have 3 goals for my talk. One is to talk about and actually show a little bit of a digital technology that we developed specifically for people who are suicidal and seeking help in emergency departments. This is like a perfect segue from Brian's talk. I want to share preliminary outcomes that were sort of brought to a halt, sadly, by COVID. And also to just talk about how we utilize people with lived experience throughout this project. And just to say, and to kind of maybe share out where I'll be heading, they were involved every step along the way, from the research as well as the content that we developed. Next slide, please. You're going to see in a moment my disclosures. Just so you know, I am a co-founder of Jasper Health, which is a for-profit organization. And I'm also funded by the National Institute of Mental Health. The next slide, please. I just want to thank and recognize, thank profoundly, not only the National Institute of Mental Health for the support of this work, but also my program officer, Adam Haim, as well as Jane Pearson, who both have just guided in really profound ways the direction of this project. I want to call out Dave Jobs, who is, of course, the treatment developer for CAMS and is a co-PI in this project, as well as my colleague, Kelly Kerner, and Topher Jerome, who during the life of this project served as our lived experience integration chair. And all the clinics, healthcare systems that contributed one way or the other to this project. Next slide, please. And the systems as well as the PIs who from those systems that contributed. It's no small thing doing work in emergency departments, needless to say. Next slide, please. So I just want to kind of frame how it is that we got here and why it matters. And fortunately, Brian already highlighted some. But I started this process as a DBT researcher and clinician. And as you probably know, people who are chronically suicidal with borderline personality disorder tend to be high utilizers of emergency departments. And what we had always speculated was the case, but now actually have empirical evidence to know it's the case. For people who are chronically suicidal with BPD, going to the emergency department is actually not just a benign intervention, but it's actually iatrogenic. It increases the risk of suicide. So all along, my and our team's interest was trying to figure out a way, like, look, if they're going to go to the emergency department, how can we make this visit actually therapeutic? But as we got more into it and through partnership with Dave and better understanding patients who are people who are suicidal, who are not only with borderline personality disorder, there are also a ton of reasons why intervening with suicide prevention, evidence-based practices in the emergency department really, really matter. So thanks to Brian, his colleagues, and others, we know that 20% of people who go to the emergency department because they're suicidal will make at least one more suicide attempt, and 10% will die by suicide. And thanks to others' research, it's speculated that if we can intervene in the emergency department, we can actually reduce death by suicide by 20%. So those are some reasons. Now, I just want to also point out that behavioral health emergencies and emergency departments, people are there 4 times longer than if you show up for a medical problem. And the relevance of that is that if you're going to be waiting 18 hours versus 4 hours while you're in the emergency department, is there a way to maximize and optimize that time? Next slide, please. So just from the perspective of a person who is suicidal, the experience of care as usual can be incredibly iatrogenic, as I mentioned earlier. And so this is how one person described it, just to provide voice to what the normal experience is. There's an incredible amount of waiting and an incredible amount of trauma being a mental health patient in the hospital. You're locked into a room, or you're handcuffed, or you're in restraints in the hallway. You're waiting, you wait for hours and hours not knowing what's going to happen. And when you finally get to talk to someone, it's strictly triage. Where are we going to put them? There's no direct intervention, no skills training, no counseling. It's just assess and go. And while this is the words of one person, we heard this again and again and again. Next slide, please. Now, what we know is that, thanks to many of you, there are powerful evidence-based interventions, generally speaking, for suicide prevention. And through the work of the Suicide Prevention Resource Center, in 2015, this consensus guideline came out, actually instructing emergency departments in the treatment of suicidal patients. So you can see there are a number of very specific brief interventions known to be effective that are recommended for folks in the emergency department. Next slide, please. The challenge, of course, is getting those evidence-based treatments to show up. And we all know the problem connected to this, right? That, many providers are not trained in suicide prevention. Many people fear treating suicidal patients. They'll say that they're afraid of making them worse. And even if they're not afraid, and even if they do know how, the concern is that, how do we ensure that these interventions show up reliably across every healthcare system? So we wondered, is it possible to actually use technology and maybe artificial intelligence powered virtual guide to actually intervene and deliver, next slide please, the evidence-based treatments that we know matter. Now, and essentially everything that's in that consensus guideline, right? Like, can we use technology to just do it? Now, the thing about technology that you may know, there are a ton of benefits. So just to be clear, technology, digital apps do not drift. They never have a bad day. They are always available, and they're available wherever a system is utilizing them, right? So there's also a decreasing health disparities aspect that I think is important just to acknowledge here. They're efficient, and there's one other thing I want you to know, which is that actually people tend to be more honest reporting out to a computer, as it turns out, than to a human being. So that's important to know. Next slide, please. As we began this process to get funding by the National Institute of Health, the first person who influenced our work profoundly was Jane Pearson. And she said, listen, if you are doing this project, you must involve people with lived experience. And I thought, okay, well, that's interesting. So let's involve people with lived experience. I reached out to Topher Jerome, who at that point had been working as a supervisor at Harborview in the Peer Bridgers program, which is a program of people with lived experience helping other people in suicide crisis. And at the time in our early research, I thought it was enough to just do a focus group or two where we got input. But as we evolved over time, and there's so much more to say about this, but just to give you the highlights, literally every protocol script, every measure that we used, every intent was vetted by a team of people with lived experience. And we didn't go forward until we had sign off from the scientists as well as sign off from the people with lived experience. So it was really this tight integration. Next slide, please. And so I'm actually we're going to show you just a very brief 2-minute clip.
As suicide rates increase and emergency departments struggle with how to effectively assess and support people in crisis, we asked, how can technology help solve the problem? Meet Jasper Health, a tablet-based application for patients to use while they wait in the ED. Developed by leading suicide experts in consultation with some of the nation's leading healthcare systems and people who have lived experience with suicide. guided by a conversational agent that reduces distress and hopelessness by helping the patient know what to expect during their visit, and immediately empowers them to complete a detailed suicide risk assessment. Jaspr includes evidence-based interventions, such as lethal means counseling, and a stability plan to help manage suicidal urges after leaving the hospital, and documents completion in the patient's medical record. Throughout the app, the patient is free to explore hours of additional content designed to help reduce distress, learn coping skills, and view videos of people who have lived experience, offering their stories of hope and strategies for living. All the patient's work is summarized to review with staff and is available on a digital companion app along with the other content for support anytime after leaving the ED. With a baseline standard of care achieved and documented, Jaspr helps patients and providers determine a disposition that is right for each patient, while offering skills and hope that can inspire recovery and save lives. Please reach out if you'd like to learn more or begin using Jaspr in your setting.
So just in the interest of time, I think I just want to highlight super quick that, we began with observational research as we were building this using a, user-centered design process with lots of testing at the bedside of people in the emergency department who were suicidal. And I'll tell you, for those of you who've worked in emergency departments and treated people who are suicidal, pretty consistently, it's like seeing the living dead there. We would walk into the room, the TV was off, the room was dark, they were in a hospital gown, and just appearing, lost and alone. Next slide, please. Next slide. So what emerged out of our early research, oops, sorry, go back one. There's a little delay. What we noticed in our early research is that people actually, after engaging in Jaspr, seemed actually less agitated and in a better mood. So we began to gather data from them. You can see this below. We were interested in knowing if, in fact, by using Jaspr, their agitation and distress levels dropped. And what we found is that, in fact, they did. That pre-post, and so give them Jaspr, they have up to 2 hours to use it and then record the same variables. We found a 25% decrease in distress and a 34% decrease in agitation, which is, again, exactly kind of what we were observing was happening, but now we had those data. And in the early research, 100% of the people recommended Jaspr to people in their circumstances, and we had no adverse events. Next slide, please. And this is just a quote from one person who used Jaspr. It's crazy that an app can make me feel like I have another person there with me to guide me through. It's one of the best experiences I've ever had in a hospital. Next slide, please. And we heard this, by the way, again and again from folks who were participating in our research. So this is these are the findings from our randomized controlled trial comparing Jaspr to care as usual. This was conducted in 2 large healthcare systems in the Midwest, hence why the sample is so predominantly white. But what I want to bring your attention to first is that it was a high-risk sample. So 74% of the folks had made a prior suicide attempt in their lifetime. 3.4 suicide attempts was the average. And the other thing I just want to drop your attention to is they had been in the emergency department for 17 hours when we first met with them. All right, so they're not just arriving, on average 17 hours. Next slide, please. So so just in terms of and as I think I mentioned, we had to bring the study to a close as soon as basically at the start of March. So this is data from January and February. So what we found is that 100% of the people that were assigned to Jaspr wanted to continue and voluntarily used it. And where we thought they might only use it for 20 or so minutes, they ended up, median score use was 85 minutes. Again, 100% of the folks recommended the use of Jaspr to others in their situation. And the thing that is important here too is that it achieved the goal. Our intention was not to develop something new and fancy. Our intention was simply to deliver evidence-based practices that were known to work. So what we found is that 100% of the people who used Jaspr created a safety plan or a stability plan. 85% had lethal means counseling delivered by a virtual guide. They learned behavioral skills. The average that they learned was 3, and they heard from people with lived experience. The average was 4 different people. Next slide, please. And this is sort of heartbreaking, but just to say it quickly, when you look at Jaspr versus care as usual, where again, Jaspr was 100%, they used the crisis plan, lethal means counseling 85%, skills 93%, PLEs 93% in terms of exposure to evidence-based treatments. Look at the care as usual column. So only 12%, again, after 18 hours, in the emergency department had anyone talk with them about a safety plan, or 6% lethal means counseling. Only 12% of them indicated that they had learned a skill, and only 6% of them indicated that they met someone with lived experience. And if we go to the next slide, we also found, again, significant difference pre-post between conditions in agitation and distress, as well as the capacity to cope with suicidal thoughts and feelings. And finally, in comparison to care as usual, the people in the Jaspr condition rated the overall experience of being in the emergency department much more positively. Final slide. So this is just, when you see it, it just summarizes everything I've already said. There are obviously a number of limitations to this work. This is the first. We had only 31 people because of COVID. It needs to be replicated. But again, I think what we, and we need to be able to extend it out to really be able to see what's the ultimate impact on actually suicidal behavior. But what we know is quite promising. And again, with a goal of simply delivering evidence-based treatments using technology, it seems as though this is an efficacious and feasible approach. I'll end there. If you're interested in learning more or learning more about Jaspr, don't hesitate to reach out. Thank you.
Wonderful. Thank you so much for this informative session, Drs. Johnson, Ilgen, Ahmedani, and Dimeff. It was really great to hear about all of your work related to justice-involved individuals, a veterans crisis line intervention, a multi-site zero suicide evaluation, and emergency department responses to people in suicide crisis using this wonderful technology. So we have just about maybe eight or so, or not, actually not quite. We're a little bit behind on our time, so we might have time for a quick question. We did have some questions that came in, and I am just going to take a look if all of the presenters could turn their cameras on so we could see everyone. Thank you again for your presentations. So we just have a couple minutes left, and there were quite a bit of questions that came in for Dr. Dimeff, actually, about Jaspr. I think some people definitely want to learn more, but just in the interest of time and trying to make sure that everyone has an opportunity to share, I was wondering if each person, and we can go in order of your presentations, could just share a little bit about how COVID-19 has impacted your research, implementation of some of these interventions, and certainly evaluation. So if we could start with Dr. Johnson, and I'll just chime in to move us along. We'd love to hear how it's impacted your work.
Sure. Well, so COVID has been bad. There are potentially good outcomes, I think, though, for the justice system, in that, sort of like telehealth, as soon as people started doing telehealth, all of a sudden things that people said weren't possible were suddenly possible. And at least in the jails, at least early on, they stopped bringing people in, which I actually think is a great outcome. And it'll be interesting to see in the analysis after the fact if there were increased crime rates, but that's what I actually think needs to happen, and better community mental health treatment. So, you know, fortunately, our data collection was finished. We have another large implementation trial that's working across the country, and I know that the jail providers are just struggling to even answer our surveys because they're so busy trying to keep on top of things in the jail. But the COVID infection rates in jail have been bad. I think decarceration has been fantastic, and it'll be interesting to see what happens in the long term.
Wonderful, thank you. Dr. Ilgen, how has COVID impacted your work and the crisis lines? They, because of what they are, maybe it's a little bit of a different experience.
Yeah, I mean, this study was done by the time that COVID began, so it didn't really affect this study. It's certainly challenging for our other research studies. I think it's really interesting to think about what COVID means for a resource like a crisis line. Some of these universally available resources, in my mind, they're probably even more useful in these times. And they, you know, especially early on when people were really afraid to get in-person medical treatment, the availability of a resource like a crisis line that was always there, that they could reach out to, they could use a chat or the phone, I think was really important. What I worry about, and part of what our study was designed to do, was to reach those people who might not have encountered those services otherwise. So I think it's tempting, especially during a crisis, to kind of sit back and wait for people to come to you who need your services. And I think hopefully the next phase in all this will be for health systems to think about how can they be going out and reaching the people that need these services.
Excellent point, thank you. Dr. Ahmedani, how has it impacted the zero suicide multi-site implementation?
Great question. I think this is really important. You know, so as you can imagine, you know, health systems made a massive transition in the way they were offering services from, you know, February of last year to March, but they made it quickly. What happened is, you know, pretty much all care was transitioned online, particularly in behavioral health. And there were a lot of, you know, barriers to making that possible prior to the pandemic. And so as Dr. Johnson mentioned, you know, there's been a lot of really great things that have come out of this. And, you know, I think we launched forward 10 years in our ability to provide care for people in behavioral health specifically, but just allowing for virtual services and telehealth. But during that time, you know, all of these interventions that were all designed to be in person had to be transitioned online and into the virtual environment. And there were a lot of questions about how to do that, how to provide suicide prevention care on the computer. It turns out you can do it pretty well. It actually went pretty smoothly, but there was a gap of several months where we had some issues. What I will say is, you know, what we saw towards the end of the year is that we were actually providing more services and more care than we were prior to the pandemic. But what you know, we have a separate study going on right now, because what I think is that the pandemic and switch to telehealth increased access for a lot of people. It reduced our missed appointments. Our ability to implement all these services was great, but it may have exacerbated some disparities. There may be some people that actually really need in-person care and couldn't get access to that kind of service. And so what we needed to figure out is, who does this work for and who does it not work for? And so that's kind of what some of the things that we're learning. Surprisingly, you know, our early data are showing us that it was actually, you know, we actually had reductions in suicide for but it's early data, so we it's consistent with a lot of the reports that have been coming out, but we're still running the numbers and making sure. So thanks.
That's great. Thank you for sharing that. And we're excited to see what else comes out of your data as it evolves. And Dr. Dimeff, we're just about out of time, but if you have something that you could share about COVID, and I will say, I don't know if you see the chats, there's a lot of questions in the chats about getting more information about Jaspr. So I think there may be a web page that someone might have found. So I just want to make sure that maybe you could put some information in the chat.
Oh yeah, it's jasperhealth.com.
Is that okay? Someone found that, so I'm glad.
Yeah,
that's
and
the right
sorry
one.
that I did not realize that you all were hearing what I was not hearing. So
no worries.
I just want to say one thing about how it impacted more than anything else. In December there was the big, it was called Newbie, the new updates in behavioral emergencies that is attended by a lot of emergency room docs and a number of our colleagues. We had a big, gathering of hundreds of people at that conference in December, only to discover where we were. And it was heart-wrenching. I mean, the people that we are partnered with were the people on the front line. So, I just want to acknowledge, and it was heart-wrenching to hear what they and their families were up against. Obviously it brought an end to our research and the other interesting thing was that people actually who were suicidal were not going to the emergency department. So it wasn't, obviously there was no place for us at the time, but, other people were staying away. Because presumably a fear of contagion. But I'll say the positive thing is that it also got us thinking about, from a roadmap perspective, like how to really tailor and modify Jaspr to be used in a telehealth context. So that will be where we're heading. And then just thinking about the benefit to rural communities that simply don't have access to all of you. So that will be next. And from my perspective, that is a fabulous lemonade out of a pretty horrific lemon. Thank you.
I appreciate that. And I think that you're right. And a big theme here is how a lot of the health systems have changed and how we're trying to move services along with those changes. And some of the wonderful work that's coming out is actually, very accessible and feasible and effective. So thank you everyone for joining this session. Thank you to all of our presenters. It's been an honor to be in a room with you virtually. You will be receiving an evaluation within the next few days. We do encourage you to fill it out. We also want to encourage you to attend our upcoming Ask the Expert Twitter event on Tuesday, March 30th. There will be some reviewing of questions that are asked during this event there. If you've not already become a member, think about becoming a member of the Injury Prevention Center. Go to their website. All sessions were recorded. So as a reminder, the recordings will be available on our website in coming weeks. We're going to take a short, now less than 10-minute break, and we're going to begin the 4 concurrent abstract sessions at 3:30. Thank you again, and thank you to our presenters. I hope everyone has a great rest of the day.